open so that we can get people back into the people's house. But right now, that's the challenge: is to get enough people access through these types of venues, Zooms or whatever, so that they can testify and have their voices heard in these very important bills that are coming up. And I'm sure if you follow Heather's website or my website, talk to us about it on email. It's paul.formica at cga.ct.gov or heather.summers@cga.ct.gov, and we'll be able to answer any questions. If you look at the CGA website, cga.ct.gov, you can plug that in and get anything you want to know about legislators, but you can also insert a bill number and learn about some of the bills that are out there. Look at the calendar to see when things are up if you can't get a hold of one of us. So thank you for being here, and thank you to my friends who are on tonight. Setu, why don't we start with you? You're the Chief Medical Officer of the Mashantucket Pequot Tribe, and I'm sure you're right in the thick of things with this pandemic, and the vaccine is beginning its rollout. I listened today a little bit. The state of Connecticut is vaccinated about almost 50% of those 75 and over. So, we're making headway. And how are you seeing things out there?
Thank you, Senator Formica and Senator Summers, for the opportunity to join you. And glad to be here with you, Dr. Schwartz, and all your contribution at the state level in planning the vaccine rollout. So certainly it's like a little bit of a deja vu for me, Senator. Back in 2002, when I joined my fellowship in pulmonary and critical care diseases, and I was at New York Presbyterian Hospital, and that's the time when the first SARS pandemic hit us. And during my research opportunity, I had the chance to work on a prototype of vaccine at the time, and we used adenovirus as a dummy vector, essentially, and transfected the same spike that we are talking about now back in 2003. And the idea was to use the inert adenovirus as a vehicle to deliver that spike gene into the recipient. In my case, I was mostly working on rodents and mice, not humans at the time. It was early stage, but we haven't really, gone too far away from the basic science of the coronavirus. And Dr. Schwartz is the expert on that as well. I'm sure he'll speak in more detail about that. The reason I bring it up is to certainly share with our audience that even though it seems like the vaccines arrived at the speed of light, warp speed, the platforms and the design of the delivery of the vaccines were in development for decades. Both the viral-based, vector-based technology, as well as the new mRNA platform of the vaccines that we are seeing with both the Pfizer BioNTech version of the vaccine and also the Moderna vaccine. They are incredible advances in sciences. They look like they happened overnight, but certainly they were in the works for decades. So, certainly that's one key point to emphasize for some folks who may be slightly, hesitant about the speed with which this arrived. And we contend with those same issues in any communities of color, especially indigenous communities that have certainly endured historical and contemporary ongoing trauma. The trust level is certainly on the lower side, and we have to earn and build that trust over time. And that's certainly part and parcel of our strategy. We need to immunize and we need to inform, both at the same time. So thank you for the opportunity.
Well, thank you. And, Dr. Schwartz, that kind of leads into, the conversation about vaccine and the rush to get it here. It's really like, some actors talk about being an overnight success 25 years later. And, there's a lot of, work going into it. So people are nervous about some things with regard to the vaccine. People who have allergies, I've heard some concerns and concerns about people who may be or want to become pregnant are their concerns. So maybe you could take us through a little bit of what the makeup is and your role on the advisory council and how you see things so far.
Be happy to. Thanks, Senator, for the invitation, and Dr. Vora, Senator Summers, good to be with you. Yes, so I'm in my day job, I'm a professor at the Yale School of Public Health, and for my career, I've been studying vaccines and vaccine science and vaccine policy. So this pandemic has brought attention to issues that those of us who think about vaccines all our lives have been thinking about, and also challenging in terms of thinking about what an unprecedented rollout of a vaccine such as this, the challenges that it brings that we continue to work through here in Connecticut and around the country. What we have, I agree with everything Dr. Vora said. We have remarkably effective vaccines and remarkably safe vaccines that we're very fortunate to have available in millions of doses less than a year after this pandemic was declared in the United States. That is unprecedented. But as Dr. Vora said, it was not an overnight success. It built upon decades of work in perfecting techniques to develop vaccines that could be able to respond nimbly if there were an emerging threat such as this one. So the groundwork that was laid helped these research trials move as briskly as they did over the summer, but without for 1 second compromising the quality, the rigor, the depth of evidence that was required by the nonpartisan, non-political career scientists at the Food and Drug Administration who looked at the data that helped support the decision to authorize the use of these vaccines earlier this fall, the Pfizer and Moderna vaccines. Novel vaccine technology platforms, highly effective. And what we've seen both during those clinical trials and now having administered 35 million doses of these two vaccines in the United States in the past few months, a remarkably positive safety profile that we've seen exceedingly few adverse events. Yes, we know that the vaccine doses in some cases can cause a day of feeling a little fatigue or a sore arm or maybe a headache or a fever. That's expected and short-lived. We've seen, Senator, as you've noted, in some rare cases, some allergic reactions, but only a few cases per million doses. We're not talking about overwhelming allergic reactions, not ones that should preclude individuals who have a history of allergies from getting the vaccine, unless it's an allergy to a vaccine component, which is a very rare phenomenon. But we're not talking about concerns about individuals with shellfish allergies or bee allergies or things like that. But beyond those known very rare adverse events, safety issues, we've seen very little, virtually nothing really, that would give us any cause for concern about these vaccines. And that's fantastic news. So we've got a rigorous body of evidence that's given us confidence in these vaccines that have been looked over carefully by the Food and Drug Administration and its independent scientists and scientific reviewers. And it's been looked over very carefully, all the data for these vaccines, by our science subcommittee of Governor Lamont's vaccine advisory group. It's a dozen of us who are physicians and scientists and researchers from across the state who have been watching the development of vaccines, both those that we have and others that are in the pipeline we may want to talk about as our time continues, looking at the data, looking at the processes by which these data were collected and analyzed, looking at the integrity of those processes, and giving our recommendation in both cases for the Pfizer and Moderna vaccines to the governor unanimously that these vaccines are powerful, safe, and effective tools that can help us turn the page on this pandemic if we can accelerate our distribution, our availability of them. So it's a really positive story. Look forward. I'm sure there are more questions we can talk about as we get together, but it's a really, it's a very fortunate place to find ourselves despite where we've been and the challenges ahead.
And Senator, if I may, while we certainly, think about how maybe build the vaccine acceptance or confidence and address the hesitancy, I think overwhelmingly, we need to really share with the audience that majority of the folks that we come in contact with are actually very grateful, eager. They have a sense of urgency, actually. So while we certainly want to address the hesitancy piece of it, we also want to recognize a sizable portion of folks who are early adopters. They have seen the data. They have seen what happens in Europe, and they've seen the rollout, and they want that vaccine now.
Yeah, I think the vaccine is what's going to bring confidence back to help generate not only, positive health and preventing the spread of this virus, but also our economic well-being moving forward is going to depend on the confidence that we're having. And, Senator Summers, you play a key role in a lot of this in the legislature and have been appointed by the governor to this advisory committee. And your job on that, I believe, is communications. You heard me say 45 or 50% of the 75-year-old plus have been vaccinated. I listened to a group talk today, the director of public health and others, and somebody said, if we had the numbers, if we had the product, we could probably vaccinate the entire state in 2 or 3 weeks with the system that's been set up. So questions coming in on Facebook say, what about me, 65 and over? Can you shed some light on a little bit about what you've been doing to set up and the communication and the different tranches that we may be in one, finishing 1A and now 1B?
Sure. Well, thank you for having us tonight. Dr. Schwartz and I have been doing forums almost every night across the state of Connecticut, and we're trying to get the information out. I want to let everybody know who's watching for the latest information. The best place to find it is www.ct.gov/coronavirus, and you can find all types of information there about the vaccine. The situation that we have on our task force is we are tasked to go around Connecticut to help facilitate where you can get the vaccine, when you can get the vaccine, who is eligible for the vaccine, and ask and answer any questions concerning the vaccine. There's a lot of information on the web, on Facebook, that is not factual. So I'm glad that we have an opportunity here with expert medical doctors and scientists to be able to answer those questions for you. And right now we have the demand outstripping the resources that we have. If we had enough vaccine, as Senator Formica has indicated, we would be able to vaccinate the entire state of Connecticut in a matter of weeks. We are set up, we have the infrastructure, we just don't have the vaccine. Connecticut is the number 4th state as far as doing the best getting the vaccine into people's arms. And because of that, we have been able and blessed to get an increase in the allocation of vaccines that we're receiving. To provide equity, as Dr. Vora was saying, to populations that are people of color and Latino and typical populations that tend to be more vaccine hesitant, the excess that we have received from the federal government will go to those specific communities where we are trying to increase the demand and get the vaccines delivered to them. As of today, 10% of our population has been vaccinated. Nearly 500,000 people in the state of Connecticut have received their vaccines. And I will be very clear that right now we are doing 75-year-olds and plus. If you're older than 75, our healthcare workers that were part of 1A are still eligible to get their vaccine. And we are starting to do some congregate housing. And I would like to just touch base on what that means. Congregate housing is typically living facilities for elderly folks where they have to share a bathroom or a bedroom. It is not including colleges. It does not include boarding schools at this point. And I do know that 1B is a long and large category of folks. It's 1.3 million people. And that's why we are rolling it out in phases because of the demand and because of the supply of the vaccine. Many people have asked us, why are you only doing 75 and above and then going to 65 and above? And the reason that we have chosen that is because from 65 and above, that age group accounts for 89% of the deaths from COVID. And then when you go 50 and above, that accounts for 98% of the deaths from COVID. So that is why an age-based rollout really makes the sense, because we are trying to get those who are most vulnerable vaccinated first. After we complete 75 plus, which we're hoping to do shortly, we will be opening up to 65 plus in the next few weeks. So we're asking to be patient. Again, a lot of this depends on how much vaccine we get from the federal government. And once we get it, I will assure you that Connecticut is very good and efficient at getting it into your arm. So I'm hoping that answers about the 65 plus. Trust me, Senator Formica and myself and these wonderful 2 doctors will make sure you know when it's your turn. One thing I would like to stress is please wait until it's your turn. We have had some situations and some issues with people trying to obtain the vaccine, not during their eligibility time. And it really puts someone who is most vulnerable at risk. So please be patient, and we are going to be persistent.
Thank you very much. That was very informative, and as you said, the 1B category is it's quite extensive, and you talk about the prisons and congregate groups, the group homes. I have a concern about the IDD population. Some of those folks cannot be isolated, away from their caregivers. Some are in group homes, and are we going to find that they're included in 1B? Many of those folks have been isolated since March when this started, and coming up on a full year. Are they part of 1B too? And
yeah, well, 1B under congregate housing, that's a very large that's a large descriptive population. I know that there were some people upset. They heard, congregate housing prisoners are getting it before me. The reality is prisoners 75 and above are getting the vaccine. Other congregate housing, when we open it up, will include group homes. It will include, college dormitories where you have to share space and you don't have the ability to self-isolate. But again, at this point, we're focusing on those who are most vulnerable based on the data that we received concerning the death rate of those exposed to COVID. I want to also share with people that these decisions are not made lightly. They are made with intense scrutiny, with a lot of time and effort put into thinking outside the box and trying to include every category that we can. The allocation committee relies on information from our scientific review committee, and also the governor's office and DPH have the final decision on who is the next category to be rolled out. Again, this is very difficult to decide. So we have to look at the science and base those decisions based on who is most vulnerable on the death rate. And again, the more vaccine we have, the better off we are, the better we are getting it in arms, the more eligibility we have to receive more vaccine.
So it seems the most popular two are the Pfizer and the Moderna one, right? Is there any way that we can just ask one of those truck drivers from Pfizer to just take a left turn toward the Capitol instead of taking a right turn toward Pennsylvania or something? I mean, I'm sure we could do something with that. That's your district.
Pfizer's in my district, and I said, can you come on, give us a deal? We're a Connecticut-based company.
Let me just ask Dr. Schwartz quickly. This vaccine, the flu vaccine, sometimes and I'll show my ignorance here, they inject a bit of the flu in you, right? To do that. Tell me the difference between what might be a flu vaccine normally and the coronavirus.
Sure. We have lots of technologies that help vaccines work, lots of different ways throughout history to help create that immunity. And in some cases, for some vaccines, it does involve a weakened or killed form of the virus or the bacteria. But that's not for these vaccines. These mRNA vaccines, contain none of the virus, nothing that can make you sick with COVID-19. It's literally taking, as Dr. Vora was talking about, the RNA, the genetic fingerprint for a piece of the virus, that by giving that to someone who receives a vaccine, our bodies generate the antibodies, generate the response to recognize the virus if it ever sees it and fights it off. That's the underlying technology. That's the underlying principle behind it. But there's no risk of getting COVID-19 from the vaccine because there's nothing infectious in these vaccines. That's one of the advantages of this new technology, one of the many.
So if we take the vaccine in the case of Pfizer, I believe it's 2, right? 21 to 28 days apart, no more than 42 days, I guess, before it really takes. So maybe it's a week or two after that before it takes hold. Can you transmit the virus to anybody, even though the vaccine may not make you sick? Can you carry it and be a carrier?
That's a great question. I'll start, and maybe Dr. Vora would want to pick up. Yep. So both vaccines, Pfizer, Moderna, they're the two vaccines we have right now. They're both 2-dose vaccine series. The Pfizer vaccine, you get your second dose 3 weeks after. The Moderna vaccine 4 weeks after. We know it takes some time after you received both vaccine doses to have the full immunity, that full 95%. That's a number those of you watching may have heard. So there is, that's why it's important both while you're getting the vaccines and even after you get the vaccines to continue doing all of those public health precautions that we've been talking about for months. That the vaccine is an added weapon, not a replacement for all of those strategies we can think about. Now, we know a lot about the vaccines. There's no doubt about them. We have confidence because of how much we know. There are things we don't yet know about the vaccines and how they perform. And one of those questions, Senator, you nailed. It's that question about how well do the vaccines help us avoid transmitting the virus to other people. We know really well now that it prevents individuals from getting sick or especially from getting severely sick, but we're still learning about the degree to which it protects individuals from just getting infected, period, without showing symptoms and transmitting it. So that's one of those reasons until we learn that knowledge, the vaccine's a great bet for individuals, but we should continue to take those precautions to protect those around us.
So that, getting the shot, getting the vaccine, being, the 95% covered, still not a license to go out without, masks at this point, and things aren't going to be back to normal quite that quickly. One of the questions we have is, does the vaccine have MCR-5 in it, which I have no idea what that is, but I'm hoping you might.
MCR-5. There are ingredients off the top of my head. I'm not familiar with that ingredient list. I can look it up during a subsequent question. We know very well what's in the vaccines because it's how it's been studied and reviewed by the Food and Drug Administration. And the vast majority of the ingredients are the RNA molecules, as well as some lipids, some fats, inert fats that are included to help administer the vaccine. So I'll follow up on that. But these questions around vaccine ingredients are often a source of concern. They're carefully studied, they're carefully scrutinized, and there's nothing in these vaccines that raise particular concerns for having reactions. So I think that's the general message to think about in terms of what's actually in the vials.
And I think in your opening you spoke to the numbers being infinitesimally small, right? 1 per millions and millions, right? That may have an effect.
Correct.
Dr. Vora, you have something you want to add to that, or?
No, I think, I agree with Dr. Schwartz, mainly that when we look at the Moderna vaccine, the incidence of anaphylaxis, which is like a life-threatening version of severe allergy after a vaccine, is only like 2.5 per 1 million doses given out. And it's about 6 cases per million doses given out for the Pfizer vaccine. So in the grand scheme of things, the chances of getting COVID and getting really sick or dying are much higher than the risk of anaphylaxis or severe allergy to the vaccine. Now, oftentimes, I think the underlying theme behind perhaps the question being asked is what the ingredient list is. And there's certainly a concern that some of the folks ask us about, will it change my DNA? I think that's sometimes the underlying fear with the mRNA platform. Most experts have, shared with us, and I have studied that as well, as these mRNAs are essentially on, self-destruct mode. They do not linger. They do not cross into the nucleus of the cell. They do not change over DNA. Now, I do share with some of my patients who have those concerns that we do know of a few things that can change our DNA and that we should be really concerned about those things. The 2 that come to mind, tobacco, smoking certainly changes our DNA over time, and alcohol consumption also can change our DNA, resulting in mutation. And both of these over time can increase our risk for cancer. But mRNA does not persist in our body. It dissolves just like a Snapchat message, and it does not cross into our nucleus to affect our DNA makeup.
Okay. Thank you. The question that just came in is that to get the second dose within that 21 to 28 days, is that critical? I think I heard today on the meeting that we had up to 40 days or so before you don't want to have it. So that question just came in. There seems to be some challenges to the VAMS booking appointment system line, which maybe after the doctor answers, Heather, you could speak a little bit about that process.
Or maybe I'll start with the timing, because that's an important point. There's some discussion about the timing of these doses, and some discussion in the media, some discussions about what's happening overseas. I think the way to think about it is very clear. Our public health officials are very clear that we are thinking of these as 2-dose vaccine series, and our goal is to administer them as close as possible to the 21 to 28 days that they have been tested and studied. That is our goal. We are not in a scenario that some are proposing where we might think about intentionally delaying a second dose for weeks and weeks and months in order to vaccinate more people. That's not what we want individuals to do. We want 2 doses as close as possible to those recommendations. However, Senator, you're right. We recognize that sometimes scheduling appointments, there's challenging. We know the supply is limited. We know that it's not always possible to hit that 21 or 28 day perfect to a T. And the Centers for Disease Control has recognized that. So they've affirmed that if circumstances dictate it, given the availability of appointments or scheduling, that up to about 6 weeks is okay. So we don't want to change the vaccination schedule across the board, but we recognize that if we can get as close as possible to that 3 or 4 weeks, recognizing that there's a bit of tolerance, that's okay. So that's the really important distinction I'm glad we had a chance to speak about.
That's the 42 days. So, Senator Summers, the supply is based. So person goes in and gets the first shot, they're kind of automatically in line at some point for the second shot. That supply is taken into consideration, I would expect, when the doses are given out. So,
right. Well, I can speak a little bit to the VAM system, and I would like to let everyone know that as one person had said to me, the system of rolling out this vaccine, it was a medical doctor, is kind of like flying the airplane as you're building it to try to get the distribution out. So the VAM system is only one of the ways that you can obtain the vaccine. And that was the system that we had received from the federal government. It has had some hiccups. They are being worked out now. So if you are someone who would like to go through the VAM system, you go online, you can register under the VAM system and make your appointment when you're eligible. And previously, you were not able to make your second appointment. It was supposed to send you a message telling you when it was time. That will be changed. So it will allow you to make your second appointment right after you've had your first appointment for your first dose. There are other ways that you can get the vaccine, especially here in Eastern Connecticut. We have hartfordhealthcare.org, where you can go online. You have to create a MyChart Plus account, which is very easy. And you can register right there. When you go for your vaccine at Hartford Healthcare, they give you an appointment for your second vaccine. That is also the case for Yale. You can go onto the Yale system and you can book your first appointment. And again, they will be scheduling you for your second appointment. The vaccine is also available at some CVS's currently, if you are eligible, again. And another great way to get your vaccine is right at our local health department, Ledge Light Health Department. And you can register at Ledge Light and register for your vaccine, and you can get an appointment for your second vaccine. So it's becoming more efficient and easier to get the vaccine every day. The first time there are some hiccups, but we've been able to work through them. If you are watching and you're in the senator's district, if you have issues with the vaccine, getting your appointment, just send him an email and we will make sure that we find a way to get you your second dose. And just to be clear, the real indication, it's no sooner than 21 days, no sooner than 28 days. So don't feel nervous if you're at day 30 or day 35. It's the real indication is no sooner than. And we were talking about reactions. That is why you're watched and monitored for 15 to 30 minutes after you get your shot, so that they can look in case anything, goes awry, which is extremely rare and has not happened in nearly 500,000 shots here in the state of Connecticut. So I'd like people to feel confident that they will be monitored and watched.
So do you need, if you get your first shot somewhere, you need to return to that spot to get your second shot?
Now, that's a good question. We are encouraging people to do that for this reason, because different hospitals have the different version of the vaccine. Some hospitals are just Moderna. So maybe the Yale system is just one brand and Hartford Healthcare might have a different brand. So we don't want you taking a Moderna shot and a Pfizer shot. You have to stay consistent. If you have been through the VAM system, where you go on and you get assigned to a place to get your vaccine, you would like to try to return to the same facility. But sometimes if you can't, you can go to Ledge Light, you can go to other places that have different versions of the vaccine. But you want to make sure you get the same vaccine manufacturer in the second dose that you do in the first dose.
And the website ct.gov/COVID vaccine that the state has says you can enter your zip code and you can find an interactive map to see what places are giving. Is that still good information?
Yes, we just launched that this week. So you should be able to go in and click on. I will warn everybody, there's not as many facilities in Eastern Connecticut as we would like them to be. Again, part of that is that the allocation is based on the population. And Eastern Connecticut, as you all may know, is not as nearly populated as the other parts of the state. I will also let everyone know that many of our health districts are ready to go. As soon as we get vaccines, they're ready to set up a drive-through vaccine clinic. They have the system down. They're trained in pandemics. Again, it's getting the allocation of vaccines.
So the illnesses, Dr. Schwartz, that may qualify, I guess, for an early vaccine if you're under 65 or under 75 or what do they call them? Comorbidities. And is there a level? Or I have a list in front of me: heart disease, cancer, lung disease, those kind of things. Do we sign up and say, this is what I have, and fill it out? Or
it's a great question, and the short answer also. Oh, I'm sorry, Senator. I was gonna say.
I want to let you answer about the comorbidities, but that hasn't been decided exactly on the rollout and how that's going to work. For example, smoking is a comorbidity, so that really has to be defined. Are you a 20-year-old smoker, and are you able to get the vaccine? So those decisions are still in the works right now. It hasn't been determined if they will continue by age to a certain point and then move into the comorbidities. So that hasn't been determined yet. And Dr. Schwartz can speak to the comorbidities that are listed on the CDC website. And if you could also touch base, either one of you, on why diabetes type 2 is listed and diabetes type 1 is not listed. I think that's important.
Sure, no, I'll happily start. I was going to echo Senator Summers' point that those questions, the particular questions in terms of how these comorbidities will shape the rollout, are still to be finalized. It was a large topic at the press conference this afternoon with Governor Lamont and Commissioner Gifford about how those will be defined and when that list will be finalized. But what we know, as Phase 1B continues, we know that at some point we'll focus on those frontline essential workers. Later in the sequence, we'll focus on those individuals with high risk conditions, and refining how those groups are identified and classified, and the timing are all things that the governor and the public health department and the advisory group will be working on. But what we have, Senator, you're right, is a resource from the Centers for Disease Control, a list of conditions based on the rapidly changing evidence that we are gathering and learning about the virus and the disease, a list of conditions where there's already a good amount of evidence that suggests that those conditions increase the likelihood of severe outcomes if one has a case of COVID-19. And then we have another list of conditions where there's emerging evidence, but maybe not conclusive, that an individual with those conditions may be at higher risk of COVID-19. So what Governor Lamont was saying this afternoon is the work of the advisory group, the public health department as well, is just think about those long list of conditions, which include lots of particular chronic conditions, how those will be translated into the prioritization frameworks in the weeks ahead. We're learning more evidence as the weeks go by. We're hoping to get more clarity from the Centers for Disease Control and Prevention, which has the best visibility of the evidence. And I think the governor has signaled that will be a really primary resource to help support those questions. But stay tuned. Dr. Vora?
Yeah, I think, the risk stratification strategy, as you described, is critical, and it's more relevant when the supplies are limited, right? Because the more complexity we add to the whole distribution, it slows down the speed, which is the essence right now. So we have to stay ahead of all the, mutations with the variants and try to get to, magical 80 or more. And certainly, comorbidities will depend a lot on honor system and attestation by the individuals. The vaccinators are not going to validate or verify perhaps in how someone says, I'm here because I have COPD. Nobody's going to ask for, show me your lung function test per se. So it's certainly, a very useful guidance in the times when the supply is not adequate. But as soon as we have floodgates open up and we have multiple vaccines rolling out, the more we vaccinate with speed and confidence, the better off we are.
Yeah. What about the other three vaccines, Doctor? AstraZeneca and Novavax and Johnson & Johnson, are they not quite gone as far in the approval process yet? And some of them, I understand, don't need the cold transport. Is that correct as well? And does it make a difference? Is one better than the other if they're all proven to do the job?
It's a great question. I'll kick things off on this front. We're fortunate. There are more vaccines coming. The cavalry is coming down the pike with respect to additional vaccines, and the most likely one that we're going to see soon is this vaccine from Johnson & Johnson, which just about an hour and a half ago, the filing to the Food and Drug Administration for that emergency use authorization was placed. That suggests we might get that vaccine available perhaps by the end of this month. That's a vaccine it's a one-dose vaccine. That's a fantastic advantage in terms of the complexity of the rollout. Senator, you're right. It's a vaccine that doesn't require quite the ultra low temperature storage and handling, which will make it easier to roll out. And most importantly, I was just talking to a reporter about this just before we came on tonight, asking about that question we're hearing in the news that says, well, isn't that vaccine not quite as effective as the others? That's gotten some attention in the past few days. And the important point from the data that we're already seeing is that this Johnson & Johnson vaccine is every bit as effective with respect to the severe disease, the hospitalizations, the deaths, those outcomes that are so critically important to getting this pandemic under control. This Johnson & Johnson vaccine, yes, it might not be quite as effective overall, but even that's a hard question to look at given how these trials were conducted. But when it comes to what really matters most, preventing hospitalizations, preventing deaths, this third vaccine that we're likely to have is every bit as powerful a tool. So that's going to help us so much, as we've all been saying, of getting more vaccines in the system, helping scale up our rollout, not a moment too soon. So Johnson & Johnson we'll see soon. And then later into the spring, maybe April or May, we'll start talking about vaccines from AstraZeneca, hopefully, and Novavax. So there are reinforcements coming to help us pick up the pace even beyond what we're doing so far.
Completely agree. And I think people ask me, what's the best vaccine to receive? And I think our standard answer is the one that you have available right there at the moment. The difference in percentage 1, 2 versus, the high 80s, I think perhaps we have done a disservice to promoting the impact of these vaccines. That instead of fixating on the numbers, I think the real value, as Dr. Schwartz mentioned, is to say that the severe disease that result in hospitalization and death are dramatically lower. And that's what truly matters, right? And I think to your earlier question, Senator, there are emerging data points that suggest that certainly there might be reduced transmission as well. We're not ready to fully come out and commit that because of absence of large-scale post-launch data just yet. But at least the AstraZeneca Oxford vaccine signal seem to suggest reduced transmission as well. So there is hope. If we have more options, more supply, the better it is.
So Heather, getting some questions in about, what is the best place for information and timelines if you're an employer? And are there specific requirements or responsibilities that employers have to get their staff vaccinated, or if they want to get their staff vaccinated, how do they do that? And then I'll let you talk about an interesting story I saw on one of the news shows this afternoon where people from New York, ages 70 to 80, came and tried to get into a CVS in Waterford. They had made appointments to have themselves vaccinated, but once CVS found out that they were from New York, they were not allowed to get there. And so, it looks like we have protections against that kind of thing, but it's not going to stop people from trying, I guess.
Right. Well, if you're an employer, you do have an option to load your roster of employees into the VAM system and create appointments that way. You do that when your business is eligible. I'm sure that you have heard some stories about, school districts that teachers were getting vaccines a little early. And, that's an example where the school district was supposed to load their school nurses. Some of them by mistake loaded all the employees. So, if you're an employer, you have that option, or your employees can go directly through the VAM system. If you go to that website, www.ct.gov/coronavirus, it has all the information on the VAM system right there for you. And I'm very familiar with the story in Waterford because I did get a call from a clinician and talked to the DPH and CVS directly about that yesterday. So there are some issues. We are hoping that people will be on the honor system. The vaccines are allocated to Connecticut based on our population. You need to be a Connecticut resident to obtain the vaccine here in Connecticut. The governor has said if you work in Connecticut, you can get the vaccine. So I think there's a little bit of a mixed message, but you need to be a Connecticut resident to obtain the vaccine unless you are loaded by your employer through the VAM system and you work at a hospital. For example, if an electric boat had put a VAMs in and you're coming from Rhode Island and you're working for them, they can set up their own clinics to have people be inoculated. So it's a little bit funny and fuzzy, but you can't get on the ferry from Long Island and come to Connecticut and get your vaccine. That would be skirting the rules. And we're hoping that people will, stay true and stay to the honor system. There are some people that have skirted and cut the line. And all that does is make somebody who's 75 or 65 in that really high risk for death category have to wait longer. So we're encouraging people to do the right thing and not to take advantage of the situation.
So you talked about essential workers, and you mentioned the manufacturers. A lot of manufacturers work in close quarters, and grocery store folks who are providing food, and restaurants and hotels and those kind of things. There is kind of a gray area in what is essential versus nurses on the front line, first responders, that kind of thing. And 1B has different tranches. Has it not quite been developed as to who goes next after 75? You're going to go to 65, and then
right.
It might take a bit to get down to teachers, for example. And I was on a meeting the other night with a number of teachers who talked about the need to feel more safe and get vaccinated. Is that?
Yeah, and I understand. I mean, I think everybody feels that wants the vaccine wants it now. We understand how important it is. But again, I have to keep coming back to the fact that the people that are at most risk, based on the scientific data, are not 30-year-old teachers. They are 65 and above. That's where 98% of the deaths are. And so, I had a teacher say, well, why do we keep getting pushed down to the bottom of the list? And that is not true. The list is a large category of 1.3 million. The priority has not been set. Even if you're included in that list, the priority has not been set. So those are decisions that obviously the scientific review committee will weigh in on as we learn more information. The governor's office weighs in, DPH weighs in. And if we had all the vaccine, everybody could be vaccinated in a couple of weeks, but we don't. So our job really in public health and on this task force, and please correct me if you think I'm wrong, doctors, is to protect those who are most at risk. So we have to look at the data. And, the age groups of which certain people, if you're a teacher and you're 65 and above, a restaurant worker and you're 65 and above, you're going to be able to get your shot in the next couple of weeks. So it's really age basis where we're seeing those most vulnerable deaths. So that's what we have to focus on and get those folks vaccinated first. And then they will slowly roll out the categories. And I will caution people that when Governor Lamont opened up the state for essential workers to go back to work, that is a different definition than the CDC's essential worker definition. So we need to be clear on that. The essential workers, when we talked about opening up the state, are very different than the essential workers according to CDC for vaccination. Some are the same, but there are some differences.
Yeah, and it'll depend on, the quantity of vaccine we get. Into your point very early in the show, Connecticut is doing so very well that we're making ourselves more accessible to more vaccine because we have a good track record. I didn't hear much about the flu season this past year, doctors. Did it just get kind of crowded out with all the talk about coronavirus? Because that's an event that kills, people every year too. And
Certainly.
This vaccine's not going to stop the flu, is it?
This vaccine will not stop the flu, but the non-pharmaceutical interventions that Connecticut folks have done fairly well, which is mainly making sure we are all masked in close contact, maintaining the physical distance, the good hand hygiene, that has really made a dent in influenza-like illnesses throughout the state of Connecticut. We knew that that's going to happen based on the experience in the Southern Hemisphere beforehand, like 6 months ago, when they went through their seasonal flu season, and they had virtually non-existent flu in Australia, South Africa. So we were hoping we would have the same trend. And lo and behold, that is indeed the case. Simple stuff works.
Yeah. Do we see ourselves continuing once this is over with the masking and social distancing? I think a lot of that stuff's here to stay. I think the Zoom thing is here to stay for some situations, but hopefully not all.
I think the need for human in-person contact will re-emerge again, but certainly there'll be a heightened awareness around universal respiratory precautions. I think the HIV pandemic made us more aware around body fluid, and it really changed how medicine and dentistry is practiced. Infection prevention, infection control practices dramatically improved. Certainly this SARS-CoV-2, the COVID pandemic, has the potential of changing healthcare behaviors and practices for the long run, for the better.
Yeah, I agree entirely. I think the days of, when this is all, over, blissfully so at some point, and, the days of going to work when you have a cold and you're coughing and sneezing up a storm and you're soldiering on, I think those days are probably going to be over. We're going to realize the ways in which we can do common sense precautions to prevent all sorts of respiratory illnesses and cold and flu season. So I it's hard to look into the crystal ball, but I do think this will show us ways in which our behaviors really can help reduce diseases, even without a magic bullet, magic fix to do it.
Yeah, I think, Senator, you were ahead of the curve a little bit a few years ago on the telehealth discussion, and I think that's certainly one of the things I think the doctor just referred to. It's going to change the way we do business and the way we, get evaluated and have conversations with our healthcare providers.
Yeah.
I would agree with that. That's something that we started in public health about 4 years ago. We were one of the first states to really push telehealth. That was one of the initiatives that I wanted to promote when I was first elected. And now we can see that there's a big push to include everyone in telehealth, not only for the convenience, but in this case, because people can continue their care with their physician via telehealth. Although it doesn't replace your face-to-face contact with your physician, it is a good, substitute in times like this. And it's also a good supplement to seeing your physician. One thing a clinician had said at one of my forums, he said, the fact that we have such low numbers in flu proves to you that masks work. There's a lot of controversy, do they work or not? But that's one of the things they kept continuing to say. And I wanted to just say one thing about teachers. I know that there is many teachers that are really concerned, but the doctors can speak to the fact that the schools have been found to be one of the safest places to be, with the precautions that schools have taken and their cleaning procedures. And you are always a priority. We are working very hard. We understand we need to get you vaccinated so we can get our children back to school and we can get our economy up and running. Again, it all has to do with the amount of vaccine that is available to us in the state. So I want you to know that there are people definitely advocating for you. But that's kind of the landscape of where we are at this moment in time. And we talk about changes. We're going to see drastic changes in our long-term care facilities after this pandemic because of the, tragic outcomes that we had. That's one of the things that public health and our focus groups, we have a special long-term care facility group that's focused on how do we improve our infection control procedures, how do we lay out our nursing homes so that we have different wings. Do we move to just one person in a room versus two? So it really has, this pandemic has changed the way that we think about infection control and social distancing in a way that I think is here to stay.
Agreed.
And the interesting thing about nursing homes, it's not like, you go to one of those chain restaurants, they're, 3,500 square feet, cookie cutter, you can put one here and one in Missouri. The nursing homes are some very old buildings, some very new buildings. And a lot of the challenges is air purification and air movement. Those HVAC systems, aren't really qualified or equipped to handle some of the new technology that we're going to need to put in. And, I know in my business, we put in an air purification system that's supposed to work. And Dr. Telehealth, good idea to continue with that. I'm sure you've been working with it a little bit. I think to Senator Summers' point, it's another tool in the toolbox, and I think it's something that's here to stay.
Yeah, even pre-COVID, most of us who were taking on call on nights and weekends, we would just do telephonic consultation with our patients who called middle of the night and triage their calls and suggest either some simple observational steps or guide them to a higher level of care, or in many cases prescribe as well. But that was on just with a telephonic interaction. Now with technology that is affording us good privacy, a good documentation of the encounter, there is no reason why routine follow-ups that do not require in-person examination cannot be conducted remotely. It's much more efficient, reduces wasted time, time away from travel, reduced contact and risk of infection in the waiting room. I think it's a win-win. I don't think it's going away.
Good. Well, thank you. Thanks, Senator Summers, for your forward thinking on that. Dr. Schwartz, anything about the vaccine that we haven't really hit? You talked about other vaccines early on that may be in developing for something. Anything you want to add or subtract at this point?
Just at one point, I'll note another question that comes up. I have 2 school-age children. I sometimes talk to parent groups. I know folks are interested in when will we start thinking about vaccines for our kids who are going to school and daycare. And I think that's another one of those issues that's off on the horizon that we need to collect more evidence for the performance of these vaccines in adolescents and children. Right now, the Pfizer and Moderna vaccines are only approved for ages 16 for the Pfizer vaccine or 18 for the Moderna vaccine and up. But one of the very active research arms in that category of things we're actively studying is we're studying the vaccines in adolescents and then younger children progressively. So that's on the horizon. Again, that's several months away. I think we need to be honest about that. But as we think about the next school year beginning and recognizing that if we want to fully vaccinate our community, even though kids are at lower risk of severe outcomes, we know that. I think the long-term future will involve vaccinating the entire population. So those with children and adolescents, like I have a 7-year-old and a 1-year-old, I think we'll find in the horizon, we'll be vaccinating them, but that's off as we think, well into the future. So stay tuned on that as well.
Agreed. And I would say that, we need more local lay champions for public health. It doesn't matter what I say or what Dr. Schwartz says or Dr. Summers and the whole expert team say. We need real grassroots champions that are here to stay to promote public health even beyond the pandemic. And I'll just make a quick comment that indigenous communities, sovereign tribal nations, they are at a 3 to 4-fold higher risk for infection and deaths. And the mortality bracket is also at a lower age group. And when a tribal elder dies, a piece of history and language dies with them. So certainly, vulnerable communities, at-risk communities have a higher challenge to really overcome any hesitancy, have easy access to vaccination, and do so that addresses 4 things. How may we conduct a vaccination campaign that is safety first with speed, equity, and efficiency, and do it at the same time with the stretch goal of 80 and 80. How may we get 80% of the eligible population vaccinated within 80 days of the start of the campaign? It's a stretch goal, but I think collectively Connecticut can do it.
Well, it seems like, the Vaccine Advisory Committee has done a great job so far, and I think you got to give the governor some kudos for the job that he's done on that. Heather, any last words you want to get? Maybe a repeat of the website where people can get information, or any other important stuff you may want to add?
Sure. If you are interested in learning more, you can go to www.ct.gov/coronavirus, and you can learn everything you would like to learn about coronavirus. We will be posting up some questions and answers, things like, if I've had COVID, should I get the shot? Do I need to get both shots? If I've had COVID, how quickly can I get the shot after I've had COVID? Everything you could possibly imagine for questions is on that website. If you just scroll down, you will find it. If you don't get your question asked and your senator is here, please reach out to Senator Formica. We will be happy to get him the information to get back to you. And Dr. Vora and Dr. Schwartz are also this wealth of information on the vaccine. And I hope that you will join us and be an ambassador to bring the correct information to the public, to your communities, to your friends in a grassroots effort. That's what we're spending time doing in the evenings, talking to different groups so that they can have their personal questions answered directly from the experts, and make sure that everyone has a chance to make their informed decision to get this vaccine.
Education and awareness, and to Dr. Vora's point, having ambassadors on Main Street, I think is very important. I can't thank each of you enough for joining me tonight. Dr. Setu Vora, Chief Medical Officer of the Mashantucket Pequot Tribe and good friend of mine. Thank you, sir. I appreciate your presence. And Dr. Jason Schwartz, who is on the Scientific Subcommittee of COVID-19 Advisory Group and a professor at Yale. I think about Yale. My dad went to Dartmouth, so we used to go to the Yale-Dartmouth games all the time when I was a kid, but we weren't rooting for blue. We were rooting for green. So, but what a great facility Connecticut has here right in the middle of New Haven and Yale, and all the great things you do. So thank you for lending time and expertise. And Senator Summers, just when I think you don't know enough, you come up with another section of the Senate that you really excel in. So thank you very much for all of your work. This is a lot of extra time, and you're balancing a number of committees, on top of all of the time that you do here. So thanks very much for your good work, getting the word out, and for joining us tonight, and all you do for the Senate.
And thank you, Senator Formica, for hosting this tonight. This was great. I will tell you, my husband is a Yale doctor. He went to Yale too, and he's had both the shots. And now we laugh and say he has superpowers. He knows how to clean up the dishes now.
So I'm outnumbered with the whole Dartmouth thing, right? I'm 2-1 at this point. Exactly. I got to be careful. I want to thank everybody for tuning in. Also, couldn't do it without the great Sarah Clark, who's behind the curtain, keeping all this going, and all the great team that we have helping us do what we got to do. So thank you very much. We'll come back and perhaps have another conversation as things progress. But remember, what's that website again? ct.gov/coronavirus, and get all your information. Thanks so much. We'll see you next time.
Good night. Thank you.
Good night.